Hello, everyone. This is Professor DePaul welcoming you back to another session of Psych 260 Abnormal Psychology Now Online. And so in today's lesson, we're going to be talking about depression and bipolar disorders. This corresponds to chapter 7 and 8 in your textbook. So we're going to start with unipolar depression, which is basically non-bipolar depression, right? So there's no manic phase, there's just a depressive state. And people that have unipolar depression makes up about 9% of adults in the US in any given year, which is astronomically high. 9% of the population suffers from unipolar depression. Around 19% have a lifetime prevalence of unipolar depression. So throughout their life, about 19% of all adults in the US suffer from depression, unipolar depression, which is once again not bipolar. The rate of depression is higher among poor people than wealthier people, obviously, because poorer people have a lot more stressors in their life. They have problems with housing, they have problems with buying food, they have problems with basically living in food deserts where it's an environment where you cannot get healthy food, you can only get unhealthy food, and that plays a role as well, poor nutrition. So all of these factors lead to poverty being a major stressor and a big predictor of depression throughout one's lives. So there are several symptoms of unipolar depression, and not everyone will have all the symptoms. So the emotional symptoms include feeling miserable, empty, humiliated, and experiencing little pleasure in life. That is called anhedonia, lack of pleasure. So people with unipolar depression just, very little energy. They feel just there's no point to life. Nothing makes them happy. Nothing ever will make them happy. As far as motivational symptoms, they lack drive. They lack initiative, spontaneity. Between 6 and 15% of those with severe depression actually die by suicide. Now, that doesn't mean if you have severe depression, you're going to be suicidal. Suicidal is, that's kind of a little bit harder to predict because you can have severe depression and not be suicidal or not attempt suicide. Suicide is more of an impulsive act. So you need the major depression with an element of impulsivity. And if you have very little motivation, you're not going to have the impulsivity to actually carry out a suicide. So there are plenty of people with depression just lack motivation to do anything, including commit suicide. Behavioral symptoms, you're less productive. There's a change in your eating habits. Now this is a little bit different between members of the population that have depression. So some members of the population that have depression will eat a lot more, and some members of the population that have depression will eat very little. And there's no rhyme or reason to this. So it's a change generally. It's either an increase or a decrease that's significant. And behaviorally, many people with depression are just less active. They have no motivation to get up and do anything, so they're not going to be very active in their lives at all. That means physically, that means engaging other people in activities. So it's not just exercise. It's not just, they don't feel like working out. They just don't feel like working in general, whether that's working out, whether that's working at their job, whether that's meeting with groups of people to discuss things that they may have previously discussed. They just want to basically stay home, do nothing. Cognitive symptoms, they hold negative views of themselves and they blame themselves for unfortunate events. So basically something's wrong with them. They believe strongly that something is wrong with the way they think about the world, the way they see the world. They're negative in some way. They're not good enough. And whenever something goes wrong, it's their fault. They tend to be overly pessimistic. Nothing will ever change. Nothing will get better. I'm a failure in life. There's no point looking for a job. It's not going to happen. I'm not going to get the job. Why should I bother? I'm going to die alone. No one would want to be with me. No one would want to be my friend. No one would want to be my romantic partner. Because I have so many things wrong with me and it's never going to get any better. So those are the cognitive symptoms, the negative automatic thinking that people with depression have on a regular basis. And sometimes they're not even aware of it. They're basically telling themselves 24/7 they're not good enough or there's something wrong with them. And this has been going on for years. So to try to break this cognitive cycle is a process. It's a long process. It requires a lot of work on the part of the practitioner, but also the patient, the client. And physical symptoms. So people with depression are more prone to headaches, stomach aches, sleep problems. With sleep problems, it goes two ways. They can either have insomnia, that means they can't sleep, or they have hypersomnia, which means they always sleep. And then the sleep problems can be exacerbated sometimes with antidepressants as well. So it can be difficult getting things regulated. Circadian rhythms fall out of order, right? So there's a tendency for people not to wake up and go to bed at the same time every day. Or there's a tendency for people's, sleep cycles to shift into becoming, more and more later in the evening. And they're waking up multiple times in the night. So they have this problem, which is a variant of insomnia. Or they're laying down at night and they just can't stop thinking about all the problems in their life and how they're basically stuck and they'll never get better. And that keeps them awake. So it goes both ways. Either they're sleeping very little, insomnia, or they're sleeping too much, hypersomnia. Now, too much is defined as probably 10, 12, 14 hours a day on a regular basis. Not just like, you were tired one day and you slept for 12 hours. That's not hypersomnia. This is like every day this person wants to sleep 12, 14 hours, maybe 16 hours. It can even be as extreme as that. So that's a problem. Hypersomnia is one of those overlooked symptoms of depression. It's not that you're just tired. If you're sleeping 12, 14, 16 hours a day, it's a good sign of depression. So here are the DSM-5 criteria. For a major depressive episode, it must last 2 weeks or more. It cannot contain mania or hypomania. Once it contains mania or hypomania, you're officially bipolar, right? Because now you have two poles. You have the manic pole and the depressive pole. So to have unipolar major depression, or what's simply known as major depression, you have to have 2 weeks of these symptoms and not a manic episode at any time period. Now that's tricky because sometimes someone that's bipolar starts out with depression and they don't show a manic phase until a year or two later. So they may get diagnosed as having major depression, and then later on in their life, they have a manic episode, and now they're bipolar. So it's a little bit tricky. It's not clear cut in people that are just starting to experience depression for the first time. Persistent depressive disorder is a variant of major depression as well. So this is low levels of depression that last 2+ years. This used to be known as dysthymia. So I kind of refer to things that the way they used to be referred to. So I may refer to this as dysthymia, but technically it's been changed to persistent depressive disorder. It's 2+ years of a low level of depression. These are people that probably go to work. They have family life. They may even have friends, but it's a drag getting there, right? It's a lot of work. They feel horribly about themselves and their situation, but they're able to do these things. It's kind of like walking depression. So it's not as severe as a major depressive episode where the person has no motivation to do anything. So they're not even going to work, going to school, hanging out with friends, talking to people. They're in bed a lot of times. They're sleeping or just not doing anything, not functioning. That's the major depressive episode. With the dysthymic or the persistent depressive episode, you have people that they're able to get by. They're your coworkers. And they're probably miserable, but you don't know about it because they can put a smile on their face temporarily while they're at work. And then when they go back home or they leave work, then, their misery comes out for all to see. And so people with dysthymia, they generally don't get treated because they feel, oh, I can go to work, I can do this, I can do that. It's not worth bothering with, right? It's not depression because it's not severe enough to stop me from functioning, but it is. It's a variant of depression, and it can greatly affect your life in a negative way. Now, sometimes dysthymia is followed by a major depressive episode, and this is known as double depression. So you're dysthymic for several years, and then all of a sudden, you sink even further to the point where you just break down, and now you're not functioning at all. So now you're in a major depressive episode. And so if you have dysthymia followed by that, it's double depression, and that's something that needs to be treated. Uh, Not that it automatically leads to suicide. Don't mistake the idea that depression is always linked to suicide. It is sometimes, but suicide is kind of a different thing. It's not just depression, severe depression. You could have severe depression and not be suicidal. So in this situation, this needs to be treated because it's double depression. It's a very severe illness, but it doesn't necessarily lead to suicide. It just leads to someone being extremely miserable and unproductive. And to your right of the screen here, you have the checklist for a major depressive episode, 2 weeks minimum, and you must have 3 or 4 of the following symptoms: weight change, so either weight gain or weight loss. Generally, more than 5% weight gain or weight loss. It's not like 1 or 2 pounds is not going to cut it. It's got to be about 5% of body weight. Appetite change, either increase or decrease. Daily insomnia or hypersomnia. Daily agitation or decrease in motor activity, meaning that you just feel slowed down, you're sluggish, you don't want to do anything. Agitation means you're restless. You can't sit still. Daily fatigue or lethargy, it's very common. Daily feelings of worthlessness or guilt. Reduction in concentration or decisiveness. And repeated focus on death or suicide, sometimes including a plan or a suicide attempt. Obviously, thinking about suicide is not the same as a plan or attempt. Many depressed people think about suicide. A much smaller percentage actually plan it and attempt it. And it must cause you significant distress or impairment in your life. And in addition to this, you can't have mania or hypomania, right? And you can't have dysthymia, which is a low-level, long-lasting depression. So some of the causes of depression include a genetic cause. So we know that researchers have found that as many as 20% of relatives of those with depression are themselves depressed, compared to 10% of the general population. So there is a strong genetic link there. And when you look at the twin studies, among identical twins, the concordance rate is 46%. That means if one identical twin has depression, major depressive episode, the other twin has a 46% chance of having it. So it's very, 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 very high. It's much higher than 10% in the general population. And even among fraternal twins, it's 20%, which is double that of the general population rate. So there's a strong genetic component here. Fraternal twins are the same as siblings, right? Because they share 50% of the DNA. So that basically, you can substitute siblings there. It's 20%. People with depression also experience a greater number of stressful life events during the month before the onset of their symptoms. And they also have abnormal neurotransmitter levels in the brain. So it's a genetic illness. There's a biological factor, but there's also an environmental factor, stress. And this goes with the diathesis stress model. You have this genetic predisposition, like it runs in your family, and then you have a stressful life event, and that triggers the expression of the gene that codes for depression. So the best way to sort of fend off this is be aware of what's going on in your family, your relatives, know if you're sort of predisposed to it, at risk for it, and then deal with stressful life events. I mean, the moral of the story throughout all of this course and learning about mental illness is if you cope with stressors, you're probably not going to be mentally ill. You're probably not going to develop depression, anxiety, etc. If you don't cope well with stressors, you have a greater chance of developing psychological disorders. And we all are different with regards to coping. There's no one right way to cope or wrong way to cope. Obviously, you want to use like more of an active coping strategy. So you want to go for therapy, go for treatment, do things like exercise, eat well, live a healthy lifestyle. That all helps. And then the poor coping skills are drugs and alcohol mainly. You want to try to avoid that. That's going to make things much worse. And as far as abnormal neurotransmitters in the brain, there's many pharmacological treatments for that if you genuinely want to go that way. And that's kind of there's a mixed account there in terms of taking antidepressants. So if you look at the biochemical basis of depression, they've mainly been looking at serotonin and norepinephrine as the two primary targets. And the reason they came up with this is back in the 1950s, they gave medications for high blood pressure, and these medications were known to cause depression. Some of these medications lowered serotonin, and others lowered norepinephrine. And we still see this today with certain blood pressure medications, especially the ones that are called the beta blockers. Beta blockers are given for anxiety sometimes, like social anxiety, situational anxiety, and they're also given for blood pressure. But if you take the non-selective beta blockers, like a propanol, you have a higher incidence of becoming depressed because of it. And so the reason why they kind of made the link here is that beta blockers block the stimulation of norepinephrine, right? So there's receptor sites like in the heart that cause your heart to speed up when these excitatory neurotransmitters like norepinephrine are produced. When your heart rate increases, your blood pressure goes up. If you block those receptor sites, you block the effect of norepinephrine, your blood pressure goes down, your heart rate goes down, but they found that one of the side effects of these blood pressure pills was depression. And so they said, oh, okay, we know how depression works now because we saw the side effects from these blood pressure pills. And so we're going to target norepinephrine and we're going to target serotonin because those are two neurotransmitters that were involved in dysregulation with the blood pressure meds. Now, have we really done a good job with this? I mean, is this sort of the biochemical basis and the way we should be looking at, like target all things that change serotonin and norepinephrine? Well, it helps, but it's not 100% successful. These drugs have had mixed results, and some of them have very poor track records. So is there more to depression than serotonin and norepinephrine? Probably. Is this what we have right now? Is this the best we have to look for in terms of treatment in the current moment? The answer is yes. The endocrine system also plays a role in depression because it modulates hormones. And people with depression have been found to have abnormal levels of cortisol, the major stress hormone in the body. So you're under a lot of stress, your cortisol level goes up, you tend to be more depressed in the long run. And cortisol is released by the adrenal glands, which are those glands that are on top of the kidneys, and they secrete cortisol in times of stress. And this is all linked up through the pituitary gland and obviously the hypothalamus, one step above the pituitary. So there's a dysregulation of that HPA, hypothalamic pituitary adrenal axis, and that could be a cause of depression. It's hard just to block cortisol because we need cortisol in the body. You can't just get rid of it. So we've gone the other route to target the neurotransmitter serotonin and norepinephrine, just because we really don't want to go around blocking cortisol because that's not a good thing. Now there's also from a macro level brain areas, including the prefrontal cortex, the hippocampus, and the amygdala that play a role in depression as well. So do we go to the macro level, stop with the hormones and neurotransmitters, and go up to the macro level and just target specific brain regions? Once again, there's not one brain region that leads to depression. So what do we target? Your prefrontal cortex is helping modulate your actions. prevents you from engaging in very risky behavior. You don't want to really mess with that though, because then you end up like Phineas Gage, the guy who had the pole shoved through his head. And you saw what happened in the case of Phineas Gage. He became extremely irritable, uh, deviant, and just not a good guy. And that was partly because there was basically a hole through his prefrontal cortex. It basically, the pole destroyed most of his frontal lobe. So that's not really the solution. The hippocampus is involved in memory. Do you really want to change that area of the brain? You might affect memory. You might create amnesia. So that's dangerous. And the amygdala is involved in primitive emotions like fight or flight. And those are survival mechanisms. So once again, what can I do with the amygdala? These are important brain structures, but it's hard to kind of take them offline if they're really involved in depression. And the evidence here is mixed, that they're involved, but so is everything else. There's a lot going on in the brain, and it's hard to sort of pinpoint depression to just one particular brain circuit. That's where we are right now, but that doesn't mean it's effective, because the drugs that we've created to treat the condition of depression, they're not effective in many people, to be honest with you. It's 50%. If you get a 50% response rate from antidepressants, you're happy with that. But there are many, many people that are just not affected. And some patients take 10, 15 different antidepressants and they're still depressed. So are we really going about it the right way? I'm not sure, but there's no new treatments in sight. And there probably will be no new treatments in the current situation with the world. I mean, everything's going to be diverted away from depression and some other things. It's kind of put on the second tier. Now let's look at talk therapy in terms of treating depression. And if you look at the psychoanalytic / psychodynamic explanation for depression, it's anger turned inwards. So once again, it goes back to your parents, early childhood, as the vast majority of psychoanalytic explanations go back to. It starts in your childhood. And this causes you to feel angry and helpless. Your parents were not available when you were younger, when you were a baby, when you were a young child. Parents are not available. If you look at it from an attachment perspective, you have an insecure attachment style. Your parents weren't there for you. And now, as you grow up, the child realizes, I need my parents to survive, and I can't direct my anger at them because I need them. Who's going to feed me? Who's going to take care of me? How am I going to live if I'm angry at my parents and they just decide to leave me? So instead of directing anger at your parents, you have nowhere else to direct it but at yourself. So now you're angry at yourself, and that leads to the depressive state later in life. They also believe in an overly harsh superego. So your superego is the morality center of who you are in terms of psychoanalysis, right? Superego develops once you pass through the Oedipal complex, and you derive your sense of morality, right and wrong, from your parents at that point. If your superego is really rigid, basically means that it doesn't give way to the id at all, because the superego and the id are kind of fighting it out, and the ego is the referee. Ego kind of tries to moderate the fight between the id and the superego. If the superego is winning to the point where it suppresses the id constantly, and you're setting very high standards for your behavior in the world, that can lead to depression because you can never attain those lofty standards, right? Like your superego expects you to be the model citizen and to be extremely successful and treat everybody with respect and do all these wonderful things, but you're a human being and you may not live up to those lofty expectations, and you may start to look at yourself as a failure and be disappointed, and that can lead to depression. So there's two routes here. You can go overly harsh superego or the emotionally unavailable parents. And they both go together because remember, the parents Resolving that Oedipal complex is where you develop that superego. And if you're not able to successfully resolve the Oedipal complex, your superego may end up becoming basically dysfunctional for the rest of your life. How do you prove any of this stuff? You don't. This is just a theory, and we can either agree with this or not agree with it. Are parents emotionally unavailable or unavailable during childhood? How do you even define that? It's kind of hard to define it, but that's what the psychoanalyst believes. From a cognitive perspective, you have a very popular view called learned helplessness. And learned helplessness was an idea developed by Martin Seligman at the University of Pennsylvania in the 70s. And he did experiments showing that dogs and other animals who experience inescapable shocks fail to escape shocks in a subsequent experiment. So what he did was he took dogs and he took other animals, I think he started with mice, and he put them in the cage. And what he did was he shocked them. And then the dog would run to the other side of the cage to escape the shock. But eventually, if the dog ran to the other side of the cage, he shocked the dogs on the other side of the cage. And then the dog would run once again back to where the dog was originally in the cage, lay down, and get shocked again. So you see the shocking behavior. So no matter where in the cage the dog went, the dog was shocked. Eventually, after getting shocked, the dog is like, where do I go? Where can I go to escape the shock? I can't. So then the dog laid down in one place and just took the shock after shock after shock and refused to move and developed a sense of apathy, just basically giving up. Like, I can't escape the shock. I give up. I'm just going to take it. And that was learned helplessness. If every action is punished, like in the case of the dog, moving from one side of the cage to the other side of the cage to escape the shock and not being able to escape the shock, right? So every action is punished, the organism gives up, does nothing, apathy. The same thing happens to human beings. If you go out in the world and you perceive that everything you do is a failure, doesn't work out the way you want it to work out, human beings give up. And you see this with applying for jobs. You apply for job after job. You send your resumes in. You even go on interviews and you get nothing. After a period of months of doing this, of sending out your resume, getting interviews, sometimes not getting interviews, and getting no job, eventually you give up. You say to yourself, what's the point? No matter what I do, I'm not getting the job, so I just give up. Or if you're in a situation where, you're trying to have a relationship, and every time you get into a relationship, it blows up, and you can't identify why this is happening, you start telling yourself, it doesn't matter, why bother with a relationship? Because it fails no matter what happens. It's always going to fail, so I shouldn't even pursue it. I'll just give up. And once you start giving up, that starts the cycle of depression. Now, it could be giving up on one thing to start, but then giving up on more than one thing, right? So once you give up on something, you're more likely to give up on everything else and fall into this spiral of depression. And with learned helplessness, that's the behavioral aspect, the apathy part of the equation. You also have negative thinking. And Aaron Beck, the famed cognitive psychologist, believed that there's 4 interrelated cognitive components that combine to produce unipolar depression. These are maladaptive attitudes. And these self-defeating attitudes are developed during childhood. So you have this belief, you have these cognitions that you're just not good enough, or you're a failure, or something will go wrong. And then when you have stressful events, later in life especially, so this has been developing all through your childhood. Maybe it started with your parents who were very critical of you. If your parents were overly critical of you, you're probably critical of yourself. You come to believe that you're not good enough. As a child, now this goes through school. to the point where you're getting bad grades and you start to reinforce that belief. My parents told me I wasn't good enough, and now my teachers are basically giving me D's and F's, telling me I'm not good enough. I'm not a good student. I'm not a good person. I'm not a good son or daughter. And these are self-defeating attitudes. That sets up a self-fulfilling prophecy. So now you have that in your mind that you're not good enough. And then when you go take on a new challenge and you fail at that challenge, you convince yourself, why bother? I knew I would fail. And then I went for the job interview, or I went to take the exam in class, and I failed. So that just reinforces the idea that I'm not good enough. I'm a failure. And it sets up a self-fulfilling prophecy. You think you're a failure. You end up behaving in that way, and you're not prepared. You're socially inept in some way or another, right? And that confirms your prior beliefs that you're a failure. Or you just look throughout your life for evidence that you're a failure in one way or another. And that creates a self-fulfilling prophecy that can be almost impossible to stop because you've been thinking this way since you were a young child. So Beck is focusing on this negative automatic thoughts, maladaptive attitudes that you can't get rid of. You're not good enough. It's hopeless. Just give up. So these are maladaptive attitudes and negative automatic thoughts. And they're so automatic you can't even recognize them because you're thinking of them all the time. And to treat this, you have to work on changing both the behavior, the learned helplessness, and the negative thinking. And that's best done through CBT, cognitive behavioral therapy. But it's not easy, and it's something that's going to be a work in progress for a long time. And you have to be willing to do it. And to be honest with you, most people aren't willing to do it. They're not willing to work hard at this, and this is very hard work. From a behavioral perspective, obviously it's lack of positive reinforcement. So let's say you're going to college and you're used to getting A's in high school, and now you get to college and you're getting C's. And you say to yourself, what's wrong with me? I'm not good enough. So that creates the negative thinking, right? So the behavior supports the negative thinking, the lack of positive reinforcement. And then we have also something called secondary gain, which is very important. Secondary gain is something that people may not be aware of. And secondary gain is this idea that your behavior results because you're getting something out of it that you may not be aware of it, right? So if you're depressed and you don't feel like doing anything, are you getting something out of playing that role, right? Let's say you're so depressed you can't go to work, you can't go to school, you can't make any money, but your parents will take care of you. They'll pay your bills, they'll pay for your meals, cook your meals, and you'll lay on the couch and watch TV. So, right, you don't have to do anything until you get better. They'll say to you, okay, you can't get a job, fine. Um, you can't do school now because you're just overwhelmed, fine. You're depressed, fine. Sit on the couch, we'll take care of you until you're better. Well, you're probably not going to get better that way because of secondary gain. Your behavior sitting on a couch watching TV doing nothing is being reinforced by your parents or by your rich relatives or by your siblings or whoever else is helping you. Now they may be actually willing to try to help you. They're concerned for you. They want you to get better. They want to help. But their helping is just reinforcing your depression. It's reinforcing your misery, your apathy. Because you're just like, okay, I can stay this way forever. There's no motivation for me to ever try to get better because I'm okay with this. I don't have to worry about my bills. I don't have to worry about food. I don't have to worry about shelter. And then eventually down the road, I'll get my act together and, you know, I'll get the job and get the education, etc. But then that goes by, years go by. Well, start with months first, right? Months go by, then years go by, and your parents are still being nice to you, but they're really hurting you. And I'm not saying everybody falls into this kind of lull, but there are people that do, and it's dysfunctional. It's all due to secondary gain. Or another situation with secondary gain is, you're depressed, so your friend will, help you with things. Go to the supermarket for you, do your laundry, etc. And that's good, right? So, you know, do I have motivation to change? I mean, I have no motivation at all. I'm just going to sit here and I'm not getting better. But by you doing these things for me, you're trying to help me, which you're really not, because you're just reinforcing this apathy. So it can be really tricky to get out behaviorally, to get out of the depression cycle, because people are unknowingly reinforcing it. And that reinforcement is called secondary gain. And it's a very important part of why people are not making progress with treatment. They may not even be seeking treatment because of this. So it's difficult. What do you do? Do you throw, should your parents throw you out? Or should your siblings throw you out of their house because you're depressed? I don't think that's the answer either. I mean, people that are depressed really are struggling. But I think they need to guide you more towards effective treatment rather than trying to treat you themselves in ways that are not working. And we know behaviorally and cognitively there are changes that lead to depression, but there's also cultural influences or environmental influences on depression, and that could include decreased social skills, social contacts. So you're not reaching out to your friends and family. You're just kind of keeping to yourself. That's going to, negatively affect you, prolong the depression. People that are divorced or separated, that's a major life stressor that's going to greatly affect people and may throw them into a depressive cycle. The depression rate of married or widowed persons, um, it's 3 times for divorced people compared to married or widowed in terms of depression. And it's even higher than people who have never been married. So the act of divorce or separation is so stressful that it's worse than, it's going to have much more impact than if you've never been married at all in your life. So you may be lonely if you've never been married, but being divorced or separated is a life-changing event. Even though the rates in this country are 50%, so like everybody's doing it pretty much, it's still life-changing for people that are in the middle of this. If you're isolated or without intimacy, you're more likely to become depressed in times of stress because you can't cope. There's nobody to help you. Women cross-culturally are twice as likely as men to receive a diagnosis of depression, but that could also be they're more willing to seek out a diagnosis. They're going for treatment versus men that are ignoring it or trying to ignore it, or even self-medicating with drugs and alcohol. Women also appear to be younger and have more frequent and longer lasting bouts, and they also respond less successfully to treatment. So there may be something here in terms of uh, women are not responding to the drugs as well. It could be a variety of factors. It could be something as simple as women experience a lot more stress than men. Women are, more prone to, dealing with discrimination than men are. And we'd like to think that in, the year, 2000 plus that, this doesn't happen, but it does. Women experience more stress. There is also a possibility of hormonal explanations, hormones triggering depression. There is that possibility as well. Although hormones are regulated by birth control, and I don't think we see the data in terms of birth control, women on birth control and depression. Um, So hormones are a little tricky because you can't really control for that. You would need more follow-ups in terms of um, different hormones, right? Not just estrogen, but the other hormones, right? And what levels they're at, and then what's the propensity for depression. And that data is kind of not really established too much. There's some data on that, but it's not a clear-cut picture as of now. So now we're going to move on to bipolar disorder. So we talked about unipolar depression, and now a much more complex illness, which is bipolar disorder. And before I get into bipolar disorder, you just need to know that in terms of depression, that if you have bipolar disorder, you're more likely to have depression instead of mania. So people that are bipolar have many more depressive cycles than they have manic phases. And it only takes one manic phase to have bipolar. So you could have 90% or 95% in terms of depressive episodes, and that little 5% could be manic episodes or hypomanic episodes, and you would be classified as bipolar. There's also a risk in terms of treating depression, unipolar depression, that if you treat people with unipolar depression with antidepressants, there's a chance you could trigger bipolar. So basically you trigger a manic episode that may or may not have come out. So there's always that chance with unipolar depression. So there's a little bit of a blurred line there. There are many cases where we think it's unipolar depression and it ends up being bipolar. So in terms of symptoms, you have the emotional symptoms of bipolar, which is active, powerful emotions, like extreme amounts of anger, extreme, high levels of arousal, right? High levels of elation. Could be a combination of these. So they are very, very highly emotional, highly a need for activity, right? In terms of motivational symptoms, they have to be doing things. Constant excitement, need for involvement, need for companionship. And this could be detrimental. So this could be someone that all of a sudden has a need to have sex with everybody, basically. And they'll go from bar to bar or place to place, having sex with strangers. And this will go on for days. And that could be a problem, right? Or it could be someone that all of a sudden they have this impulsive need for buying things. So they go store to store and they're spending thousands of dollars and they're maxing out their credit cards and they're buying things they cannot afford. But they have this real pressure, this real impulse to just buy, right? And then there's no boundaries, there's no guidelines, there's no stopping point. It's out of control. Behaviorally, they may move quickly, talk loudly, talk rapidly. You could definitely see symptoms because they'll talk and they won't slow down. So they won't pause, like we all pause when we have a conversation. They'll just have this need to talk, and not stop. You may see them moving at a fairly rapid rate, right? So body motion, I'm not just talking about walking faster, I'm talking about moving their body in a sort of agitated state. You may see them behave very flamboyantly, without any sort of concern for how other people are viewing them. In terms of cognitive symptoms, they have very poor judgment, very poor planning. So they're not productive in any way. Although if they're hypomanic, so if it's scaled down a little bit and they're just a little bit manic, they can be very productive. But in terms of full-blown mania, it's really hard for them to stay productive because there's a constant need for stimulation. They can't just sit there and do something. There's a constant need to keep going. So in the full-blown manic episode, they're very unproductive. They can have trouble remaining coherent or in touch with reality. So a lot of times on the upper end, so if you're in a full-blown manic episode, there is elements of psychosis. So you may be somewhat delusional, or you may have hallucinations as well in the full-blown mania. So sometimes it's difficult to make a discrimination between psychosis and mania. I mean schizophrenia, I should say. Schizophrenia and bipolar mania. Those disorders can get kind of blurred because the bipolar manic patient will have overlapping symptoms as the schizophrenic. And eventually, it'll calm down over a period. I mean, manic episodes don't last really more than days to a week. It's not going on like as long. The depression lasts a lot longer than the manic phase. And in terms of physical symptoms, they have high energy. They have no need to sleep. So they can sleep a couple hours and feel super recharged. And you may sound that feels great. Well, it is. If you have a little bit of mania, so if you're hypomanic, it could be a very pleasant state for people. And they could be very productive, and they may really, really enjoy it. But if they're in full-blown mania, they're just out of control. And no need for rest, no need to stop talking, need for constantly doing things, and it can get them into trouble. So here are the criteria for bipolar. You need to have a manic episode for at least a week. And this is continually abnormal, inflated, unrestrained, or irritable mood, as well as heightened energy or activity most every day for at least that week. And they need at least 3 of the symptoms: grandiosity or overblown self-esteem. So this is basically they think very highly of themselves, very unrealistic thinking. Reduced need for sleep, increased talkativeness or drive to keep talking, so basically they'll talk without pausing. Rapidly shifting ideas or the sense that their thoughts are moving very fast. So everything's just kind of sped up. Attention's pulled in many directions. Heightened activity or agitated movements. And excessive pursuit of risky and potentially dangerous / problematic activities. This must cause significant distress or impairment. And we make we distinguish between 2 types of bipolar. So bipolar 1 occurrence of a manic episode, and then hypomanic or major depressive episodes may precede or follow the manic episode. In bipolar 2, there's a presence or history of major depression. There's a presence or history of a hypomanic episode, and there's no history of a manic episode. So the difference really is that in bipolar 2, you have hypomania, and in bipolar 1, you have full-blown mania. And they always cycle with depression. So they're always cycling with major depression. So if it's full-blown mania and then major depression, it's bipolar 1. If it's hypomania and then major depression, it's bipolar 2. And this is what this slide is basically showing. Bipolar 1, you have the full-blown mania alternating with major depressive episodes. Now remember that the major depressive episodes are going to occur much more frequently than the manic episodes. You could have one manic episode and then long periods of depression. Some people experience an alternation of depression and mania. Other people have mixed episodes where they have depression intermixed with mania, which creates a very, very unstable situation. So there's no clear shift. The shift could be hours, if not days, from depression to mania, and that's called a mixed episode. In bipolar 2, you have the hypomania. So I guess you want to consider bipolar 2 easier to treat, although the major depression is still very difficult to treat. The hypomania generally does not encompass psychosis. So people with hypomania don't have these delusions of grandeur or other psychotic symptoms that people with full-blown mania have. If you experience 4 or more episodes within a 1-year period, the disorder is then classified as rapid cycling. So that means you're cycling between depression and mania pretty quickly. In most cases, though, depression occurs 3 times as often as mania and lasts much longer. So you're getting mostly depression with the bipolar disorders. You're getting a little bit of mania or hypomania, but you're getting mostly depression. The prevalence is 1 to 2.6%, between 1 and 2.6% of all adults at any given time, which is still pretty high, but much lower than unipolar depression. And then the lifetime prevalence is about 4%, which is still a large part of the population. 4% is pretty big. Bipolar 1 seems to be a bit more common than bipolar 2, and these disorders are equal between men and women. Women, however, may experience more depressive episodes and fewer manic episodes than men, and rapid cycling is also more common in women. And these disorders are more common among low incomes than people with higher incomes. Once again, the additional stressors of having low income. Even in the situations currently in the world, people who have low incomes are at much greater risk of things than people with high incomes. And so there has to be more of an emphasis on going out to areas that have people living in poverty and getting them the appropriate treatment. Unfortunately, if you have a low income or you're impoverished, you can't afford to go to a psychiatrist. You can't afford to get medication. So what ends up happening is either you end up in a hospital, in the ER, and they're treating you, temporarily treating you, or you're getting no treatment because you don't have the money to pay the exorbitant psychiatric fees, right? You can't pay a psychiatrist $300 to diagnose you and treat you, and then pay them $200 every treatment session. You don't have that money. So you get no treatment. Or maybe you see a primary care doctor that you pay less money to, but they have no idea how to treat you. So there's a huge advantage to having a high income. It really offsets a lot of the problems in terms of mental illness. And it makes treatment a lot easier too. Cyclothymic disorder is similar to dysthymia, except in this case, you have a hypomanic episode. So you have an episode of hypomania, and you have an episode of mild depression. So remember, with dysthymia, you had a milder depression that lasted 2 or more years. Here you have hypomania mixed with the mild depression that lasts 2 or more years. And this is pretty rare. It only occurs in about 0.4% of the population, and eventually it can turn into bipolar 1 or bipolar 2. So that basically means that either the hypomanic episode becomes a manic episode over time, and or the mild depression becomes severe depression. And now you have bipolar 1 or bipolar 2. So cyclothymia is mild or hypomania and mild depression alternating for 2 or more years. Causes of bipolar disorder, well, neurotransmitters. So after finding a relationship between low norepinephrine and unipolar depression, early researchers expected to find a link between high norepinephrine levels and mania. And there's some evidence for this, that norepinephrine is pushing people into a manic episode. Although there is no relationship with high serotonin, bipolar disorder may be linked to low serotonin activity. So this is the theory with regard to serotonin and norepinephrine. If you have low serotonin levels, that may kind of open the door or predispose you to a mood disorder, and then permit norepinephrine to define the particular form of the disorder. So it's basically saying that low levels of serotonin makes you vulnerable to a particular mood disorder, and then the norepinephrine levels determine what disorder you have. So if you have low serotonin with low norepinephrine, you're going to have depression. And if you have low serotonin with high norepinephrine, you're going to have mania. So how do you alter it, right? How do you block norepinephrine if you think norepinephrine triggers mania? And there's no particular drug that functions just at norepinephrine. It's sort of blocking norepinephrine, but you have mood stabilizers that are used now to sort of prevent the manic episodes. Another biochemical cause, possibly, is ion activity. So ions are positively or negatively charged cells. And there's some evidence that there may be sort of an improper transport of these ions in individuals with bipolar disorder. So you can think of ions as the sodium-potassium pump, which creates the membrane potential, right? The difference in charge between inside a cell membrane and outside a cell membrane. And that occurs in the neuron as well, which is a nerve cell. But you don't need to know all the details of this, but that's kind of what's happening here is, the membrane potential, which is derived by the movement of ions, is somehow disrupted. That there's some irregularity in these ions, and it causes the neurons to fire too easily or too slowly. So if they fire too easily, it's a manic response, or they fire too slowly, it's depression. So you can think of action potentials. That's the neurons firing, right? So if they fire too easily, action potential occurs too easily, it's mania, and if it occurs too slowly, it's depression. It's a pretty complicated system, and it's not exactly known how to treat this other than the use of the anti-bipolar drugs, right? The lithiums and the dipicones. And there's some belief that the potassium and calcium ion channel abnormality exists, and that lithium can regulate this. So lithium actually can regulate the voltage-gated potassium channel that controls how fast a neuron depolarizes or fires an action potential. So lithium's a mood stabilizer, but lithium is a toxic metal if consumed in a high enough dose. But there's some evidence that the lithium will alter this ionic disruption and fix it. And maybe it does do that, but it does that at a great cost in terms of enormous side effects. In terms of brain abnormalities, post-mortem studies, right, so autopsies, and other brain imaging techniques like fMRI has identified a number of abnormal brain structures in people with bipolar disorder. In particular, there's disruption of the basal ganglia and the cerebellum. And we know that both of these structures are involved in memory, more specifically motor-based memory or implicit memory. Cerebellum is also responsible for fine motor control. And there may be some abnormality in both of these structures that's leading to this manic episode. We're not exactly sure what's going on here, but these are two targets that need to be studied more extensively, both at the molecular level and at the macro level through brain imaging. Genetic linkages are always part of any discussion of any disorder that we talk about. And if you look at twin studies, identical twins have a 40% concordance. That means 40% of identical twins both have bipolar disorder. And amongst fraternal twins, that drops all the way down to 5 to 10%. In the general population, it's only 1 to 2.6%. So fraternal twins still have an elevated risk compared to the general population, but it's much less than identical twins. So that shows a really big component or influence of genetics. Because identical twins or monozygotic twins share 100% of their DNA, whereas fraternal twins or dizygotic twins share only 50%, including siblings. And that big jump from 5 to 10% to 40% is showing you that the genes are playing a huge role. Maybe the genes are causing the abnormality in terms of the cellular mechanisms that I was talking about in terms of ionic transport. That, a gene can alter the membrane protein that allows the potential, right? The membrane potential to exist. And so it can cause certain neurons to fire more easily if that protein that's embedded that transport protein that's embedded through the cell wall is somehow deficient or defective in some way. And that can be all done at a genetic level. And maybe it's the fact that there's some kind of mutation that's happening that's causing this, and it's evidenced by the 40% concordance here with identical twins. So everything is genetic. You can say that everything is also environment, nature versus nurture. I tend to be more of a nature person than a nurture person, but I readily admit that both of these forces influence or cause the change in the disorders. In this case, it's a very strong genetic linkage. So there's probably a combination of genes that are disrupting what's going on and leading to bipolar disorder. Whether it's disrupting the ions or disrupting the neurotransmitters or both, we don't know exactly. There needs to be more research on this. And obviously research in the areas of mental disorders is pretty slow compared to research in the order of cancer or viruses or things like that, right? So I know I was complaining about funding with regards to mental health problems. That funding situation is going to get much worse now. It's going to be even less money, even less funding to this particular problem because of all the other prominent issues in our environment, in our society. And so this research is kind of, it's going to have to continue either non-funded or it's going to be delayed because other things are deemed as higher priority right now. In terms of treatments, we know for bipolar disorder, therapy is not very effective. So you can't really do effective cognitive behavioral therapy or dialectical behavior therapy or even psychoanalysis. I mean, I'm not a big fan of psychoanalysis, but I can't see how psychoanalysis is going to fix a manic phase in a bipolar patient. It can be helpful as kind of something to help the patient organize their lives, sort of, make the best in terms of when they're manic, they can get certain things done. When they're depressed, they need to sort of conserve energy and sort of schedule their lives in a certain way. But the medication is what's really stopping the manic phase. It can help with the depression. The therapy helps more with just the depression part, but the therapy as a whole has not shown a lot of utility for a manic phase. It's very difficult to have a conversation with someone in full-blown mania. It's similar to having a conversation with someone that has severe schizophrenia. You can talk to them about a variety of things, but they're going to be delusional. They're going to just say and act and do things that are just not sort of conducive to getting better. It's a very difficult task, and I can't see how cognitive behavioral therapy can really work with someone in the midst of a manic phase. Depressed clients can also be too passive to fully participate in therapy. So there's problems just doing therapy with depressed people, and there's a lot of problems with doing therapy with someone in a manic state. So it makes it doubly difficult to get therapeutic work done. And medication to stabilize the person is probably the first step. And once they're stabilized, that means once they're no longer having manic phases and extreme depression, you can then start the therapeutic sessions. But if they're bouncing back and forth between mania and depression, or they're in full-blown mania, it's going to be very difficult. So there are problems with depression, but there's problems with mania as well. Behavioral interventions, like I was saying before, give them a schedule. Get them onto a set schedule. Get them up the same time every day. Get them to sleep the same time every day. Have them engage in pleasurable activities and events. Reinforce their non-depressive behaviors more than depressive behaviors. Help them develop social skills. And then, most importantly, take their medications. That's not behavioral, but it is kind of behavioral in the fact that you have to get them to adhere to medication on a schedule, set schedule, not to stop taking their medications, and the medications are horrible. So once again, they're going to want to stop taking their medications. They have to stay on their medications, or they're going to go back to this yo-yoing between mania and depression. Cognitive treatments will, once again, work better when the patient is no longer in a severe depression or a manic phase. If you get them stabilized with drugs, um, there is some success with cognitive treatments. So 50 to 60% of clients show a near total elimination of symptoms if they're stabilized with medication first. And there's 4 phases of the treatment that involves increasing activities, elevating mood, challenging their negative thought patterns, which is a tendency to lead to depression, identifying negative thinking patterns and biases, and changing primary attitude. So cognitive therapy works much better for depression. It doesn't really work for mania. Mood tracking also works really well for depression. So you have them keep a journal and note the situation that causes their moods to either increase or decrease. So they start making a connection. I get depressed every time I go here or every time I think about this, and then they can stop and they can identify what's triggering it. And you can even do this on your smartphone. So that now there's mood tracking apps you can download and you can keep track in real time. What's the triggering event? What's triggering your depression? What's triggering you to put you in a bad mood? And then to work around that, right? So maybe it's your interpretation of the event. Maybe it's avoiding the event if possible, avoiding the situation. A lot of times it's interpretation as well. And we also want to be cognizant of the fact that we should use multicultural treatments when treating depression. And it appears that cultural sensitive approaches can help minority clients overcome their disorders better. And this could be just understanding their culture, getting familiar with it, getting familiar with their traditions, or how they feel about them. Or maybe even having a therapist, of the same race or ethnicity. In some situations that helps create rapport. It's not necessary, obviously, but in some situations it helps create the rapport between the client and the clinician. And as I was saying before, a lot of minority clients don't have access to medication, and this also relates to the fact of, a lot of people don't have access to money. And if they don't have access to money, it's going to be harder to get an appointment with a psychiatrist who's going to adjust your medication every couple of weeks. And it's a struggle. And there are some psychiatrists that will do sliding scale, but there's not many. There's a lot more therapists that will do sliding scale and adjust their compensation depending on the income of the client. But psychiatrists are a different ballgame. They want to get paid. They're not willing to take $20 from Medicare or Medicaid. A lot of them are not willing to take $20. So getting treatment by a psychiatrist can be quite expensive depending where you are. There are some people that will adjust and will take clients that are less affluent, but even finding psychiatrist offices in certain neighborhoods is difficult. And we need to work on getting people that don't have money, people that live in cultural neighborhoods or cultural enclaves that may not have access to all the support systems they need. We need to we need to do a better job of getting these people the treatment that they need. And it's not just Medicaid. It's not just all that that system, because a lot of doctors don't even want to take Medicaid. It's more of we need to get people that can identify with the clients and that are willing to take less money to do a good thing for society. And you're seeing that right now. People are doing some really good things for society. They're helping their neighbors. They're helping people in the community. But then you also see people that are doing the opposite. They're being extremely selfish and they're caring about themselves and no one else. Or they're taking advantage of other people when other people are down, other people are struggling. And it's going to take a little bit more of a selfless attitude to really address the needs of many people. We also have a family-oriented technique that you can either get through marital or family therapy, which is extremely popular, very, very popular these days. Probably the fastest growing field within psychology in terms of therapy is marital and family therapies because they're needed all over the place and they can make good money in the long run if they're good at it because there's always a demand for a good marital family therapist. And there's something called interpersonal therapy where the therapist identifies 4 interpersonal problems that can lead to depression. These include interpersonal loss, like death, someone you love died, or it could be also, loss of a job can create this as well. Interpersonal role dispute. This can be in a marriage or a family that there's not cooperation. There's not this idea that this is what you should be expected to do. You should help me with, taking care of the house in addition to keeping your job. And this challenges the chauvinistic ideals of the 50s and 60s that persist in some households to this day. Right? Like, I went to work, so now I come home and do nothing. Right? Well, if a man says that, what's a woman to say? Because a woman is probably also going to work too and doing a million other things, right? Chores, taking care of children, cooking, cleaning, and there should be a more equal balance of labor in the household. And there is to a degree. I mean, this has been changing over decades, right? Where labor is becoming more evenly split. But there are occasions where, you have some chauvinism, and the chauvinistic male will not sort of adapt to this. And that can create huge kinds of interpersonal disputes within the family. You also have interpersonal role transition. This could be, going from marriage to divorce. This could be getting a new job, making more or less money, being fired, etc. And then interpersonal deficits, which is generally a communication issue. That there's just lack of respect, lack of communication, and a married couple doesn't talk to each other. They only fight, or when they communicate, it's in a very aggressive way. There's just lack of communication. And that can lead to dispute and lead to depression in some cases. So now we go back to the biological therapies. As far as treating depression, I went through the drug therapies. So on a related note, if drugs don't work, the antidepressants don't work, you have various biological therapies. Now, in terms of the antidepressants, I just want to go through this fast before I move on. You have different types of antidepressants, right? You have the SSRI drugs, which is, Paxil, Zoloft, Prozac, Lexapro, all those drugs. They work mainly on serotonin. And then you have the drugs that work on both serotonin and norepinephrine. I will talk about that shortly. But this is the main treatments, the SSRIs and the SNRI drugs. You may take several courses of them, and they may not work. That's the first treatment is the drugs in terms of biological therapies. If the drugs don't work, let's say you take like 5 different drugs and you have no success at all, and you're still extremely depressed. Some patients will take up to, I've seen 15 different courses of antidepressants, and they're still not improving. The antidepressants are not a panacea. They're not perfect for everybody. There is going to be some failure rate, and that failure rate could be relatively high. If that doesn't work, if multiple courses of antidepressants don't work, you can try a biological treatment. And probably the number one biological treatment used is electroconvulsive therapy, which is electroshock therapy. This procedure is used in other countries for schizophrenia as well. And it's been shown to be effective in treating people with severe depression accompanied by psychotic symptoms like delusions. So in the case of someone who's severely depressed, electroconvulsive therapy does work. It is not barbaric as it is depicted. So it's not One Flies Over the Cuckoo's Nest, where you saw that movie and it was just a barbaric depiction of people getting shocks and being severely, they look like in severe discomfort, right? It's traumatic. In this case, electroconvulsive therapy has undergone so many revisions that they basically put you to sleep. You are heavily sedated, and then they give you the shock treatment. So you're basically sleeping while it's happening. And then you wake up and it's all over. So it's not like your body is being contorted by the electrical shocks and you're going to break fracture your spine or your ribs or, because your body is being shocked into submission. It's not barbaric like that. It's a very calm process where you're basically under anesthesia. And they do it for about 10 weeks, once a week for about 10 weeks. And it works for some people that have refractory depression that the antidepressants don't treat. However, just because your depression improves, your memory does not. So many people have severe memory impairment. So they'll be missing big gaps of their life after treatment with ECT. And they may even have what's called anterograde amnesia. So forgetting about the past is called the retrograde amnesia. Unable to form new memories is called anterograde amnesia. They may experience also anterograde amnesia in addition to retrograde amnesia. So not only are they losing bits of the past, they may have trouble forming memories moving forward for a while. And no one knows exactly why this is the case. Are you disturbing the brain in such a way that you're, altering the formation of memory through the hippocampus, through the amygdala and hippocampus, that sort of combined route? Is it some kind of ionic disturbance? Is it preventing long-term potentiation on a molecular level? We don't really know exactly why there are these big gaps in memory, but there are those big gaps. And that's the major side effect, and that's a big side effect. You may lose a significant portion of your memory going back for multiple years in some cases. Now, the memory can return in some patients after the ECT has been stopped for a while, but that's not guaranteed. There are some people that have permanent memory loss. So this is a last resort treatment. It does work for a lot of people with severe refractory depression, but the memory loss is a major side effect, and it's up to the individual to risk the possible profound memory loss versus, being so severely depressed and suicidal in some cases. It's a risk-reward thing that has to be a situation that has to be worked out for each individual client. Now I get to drug therapy. So early drug therapy, as I mentioned, drugs are not the panacea we want them to be. They're not the cure-all, and they fail in a lot of patients. Starting in the 1950s, there were two drug classes that were used. One was the MAO inhibitors, the monoamine oxidase inhibitors, and these drugs block basically the reuptake. They basically block the destruction of certain neurotransmitters. So monoamine oxidase basically blows up or destroys certain neurotransmitters, break them down. And so this drug prevents that enzyme from breaking down neurotransmitters, and as a result, you have more serotonin and norepinephrine available in the synapse, right, of the neuron, in the synaptic space. The problem with MAO inhibitors are they're a pretty effective drug for depression. The problem with these MAO inhibitors is they have a significant interaction with tyramine. And tyramine is a substance that's found, I should say, in red wine. It's also found in some very rich cheeses. And if you have these foods that contain tyramine and you combine them with the MAO inhibitor drug, the side effect is basically a hypertensive crisis. So people's blood pressure would shoot well up over 200, and they would need emergency treatment because they're at risk for stroke. It could be deadly in some cases. So having a near fatal or fatal side effect really restricts these drugs. So these drugs are given only under, the occasion that nothing else works, because of the dangerous interactions with tyramine, which is found in cheese and red wine, and the hypertensive crisis that it causes. So you can't really get these drugs. They're almost never given out for depression. A more common drug that it's frequently given out for depression, amongst other things, are the tricyclics. And these are the Elavils. It's a very common tricyclic. There's other tricyclic drugs that impiramines, another tricyclic drug that's given for OCD, things like that. These drugs are effective because they work on both norepinephrine and serotonin. They increase the levels of norepinephrine and serotonin, which, by the molecular theory of how these drugs work, would decrease depression. They also cause increase in histamine release. And histamine will make you very sluggish, very tired. It'll put you to sleep, basically. It also makes you gain weight. So the side effects of the tricyclics are extreme fatigue, which is why you want to take them before bed, because they have a very highly sedative effect. And they're used for, also the other side effect is weight gain. So weight gain is greater on the tricyclics than they are on the SSRI drugs. So that's another thing. And also, the rare side effect is arrhythmia, heart arrhythmia. So it can lead to this prolonged QT syndrome that I talked about a few lectures back. And so someone that's susceptible to a heart arrhythmia could technically die from it, because it basically prolongs this QT interval. And so that's basically the period between the heart contracting and beating and then repolarizing and filling with blood again. So if your heart beats and then stops, it doesn't refill with blood and beat again, the person will basically pass out and eventually enter a very dangerous arrhythmia pattern known as ventricular tachycardia and then ventricular fibrillation. And once you're in those degenerative patterns, right, heart rhythms, it can eventually lead to asystole, which is basically no heart rate. And that leads to death within a very short period of time, a matter of minutes. So if you're prone to any kind of heart abnormality, these drugs will be, contraindicated. You can't use them. But for most people, they're pretty safe. They're not going to cause cardiac arrhythmia for the vast majority of people. And the main side effects are extreme fatigue and obviously weight gain. And the weight gain can be pretty severe. These drugs were used sometimes off-label as a sleep aid for people with severe insomnia. They can be used off-label for pain regulation. Whether that pain regulation could be diabetic neuropathy, where people with diabetes have nerve pain because the diabetes has caused the nerves to be damaged. They can be used for things like more painful disorders that people have severe symptoms like fibromyalgia, unexplained muscle pain that occurs throughout the body, mostly in women. 90% of the cases are in women. But these have various effects. They're used for irritable bowel syndrome, gastrointestinal, contractions, abnormal contractions in the colon, basically, or sensitivity, abnormal sensitivity of the colon. And they work for those conditions as well. So it's a very versatile drug class that's been around since the 50s. And it can be effective for depression, although the side effects are kind of too much for most people. So the second generation antidepressants have been developed. Actually, let me talk a little bit more about the MAO inhibitors first. As I mentioned before, MAO inhibitors break up dopamine, serotonin, and norepinephrine, and they cause high blood pressure when you eat foods containing tyramine, cheese, banana, wine. They're effective drugs, but in my opinion, they're too dangerous to give out. Because, telling someone, do not eat this list of foods, it doesn't matter how much time you spend telling them this, they're going to screw up. People don't follow directions, right? If they don't take the medication the way they're supposed to, they're going to screw up. They're going to eat something on the list. They're going to end up in the hospital, and they could die from it. So it's too much risk for a psychiatrist or primary care doctor to give this. This is used in the last situation. It was originally used to treat tuberculosis. Obviously, antibiotics are much more effective at treating tuberculosis. And the medication side effect was it made people happier. And it does make you happy, but at the risk of possibly dying from a hypertensive crisis if you eat a banana. To me, that's a risk that's too great to actually trust anybody with. And as I mentioned before, the tricyclic antidepressants are very effective for pain management. They have a bad side effect profile, as I mentioned, weight gain, sluggishness, heart rhythm abnormalities. They work by preventing reuptake of norepinephrine and serotonin. So they're very similar. They're very similar in function to a drug class I'll talk about, which is the SNRI drugs, the serotonin and norepinephrine reuptake inhibitors. They're very similar in function to that, except they work differently. But pain regulation, very effective. There's a muscle relaxant called Flexeril, and Flexeril has the same molecular shape, almost entirely the same as Elevil, which is amitriptyline, which is a tricyclic antidepressant that's used for chronic pain. So these are very effective drugs for back pain. They can be effective for headache sometimes. Obviously, I told you about the functional gastrointestinal pain. We're not talking about Crohn's disease or colitis. We're talking about functional disorder like irritable bowel syndrome, where there's no organic damage to the intestinal tract. It's just more of like abnormal sensitivity of pain or extreme muscle contraction. So they're very effective drugs for a lot of people. 60 to 65% of patients get improvement in depression. They have to be taken for, I would say, a minimum of several weeks to have a maximum effect. Usually antidepressants take about 6 weeks to have peak efficacy. And they're called tricyclics because they have a ring-like structure, a 3-ring molecular structure. They're effective drugs, but the side effects kind of are too high. Only take them if the other drugs don't work. Here's a diagram showing the blockage of the reuptake with tricyclics. So as you see, norepinephrine and serotonin are released from the synapse, and they're trying to bind to the postsynaptic neuron on the left. And you see on the right, you see those protein channels that are embedded in the synapse there, in the cell membrane of the neuron. Those are the voltage-gated protein channels where the ions flow through it, and they produce they reuptake or repackage the neurotransmitter, right? So the excess neurotransmitter in the synapse gets repackaged by the presynaptic neuron. It's kind of like recycling. Whatever doesn't bind to the other receptor sites on the adjacent neuron gets repackaged and saved for later. Well, the tricyclics and all the antidepressants pretty much will break or prevent the reuptake or the repackaging of these neurotransmitters. So if you prevent the repackaging of the neurotransmitters, they stay in the synapse a lot longer. So they kind of just float around in the synapse. And if they're floating around in the synapse, eventually they're going to bind to empty receptor sites. And that's how the drugs are going to have a better effect, is because they're going to allow more neurotransmitters to bind, and therefore the neurotransmitter will have a more potent effect on what the other neurons are doing, firing or not firing. And if the excess neurotransmitters are kind of sitting around in the synapse and they can't go get repackaged, they're going to bind eventually. They're going to have an effect. And that's kind of how these drugs are working. And this works with the SSRI drugs too, is they're preventing a reuptake. In this case, the tricyclics are preventing a reuptake of serotonin and norepinephrine. And therefore, serotonin and norepinephrine are going to have greater effects on the adjacent neuron. It's going to cause an action potential, or it's going to inhibit. In the case of serotonin and norepinephrine, it's going to cause an action potential. In the case of GABA, it would inhibit an action potential. So, talking about those selective serotonin reuptake inhibitors, these are the second generation antidepressants. They have a much better side effect profile than the tricyclic antidepressants. They are structurally different from the MAO inhibitors and the tricyclics, and they're better. They're more effective, and they're a hell of a lot less dangerous. I mean, tricyclics are pretty safe. I mean, they have some nasty side effects in terms of weight gain. That can be pretty excessive. But MAO inhibitors are just downright dangerous to be giving to patients who can't follow directions. So these drugs, the SSRI drugs, they're very safe. You can't really overdose on them. The worst thing that would happen is you would get serotonin syndrome, you'd be vomiting, have diarrhea, feel very, very sick, go to the hospital, they treat you, you go back home. Whereas if you overdosed on tricyclics, you have severe problems because they're going to affect the heart. They're going to affect the heart rhythm. They can be dangerous. If you took like a lot, if you took like a whole bottle of them, which obviously is not advisable, you'd be in serious problems. And MAO inhibitors is a different story. They're just downright too dangerous from my perspective. SSRIs are very benign. They're not going to cause any problems if they're abused. They're not addictive. You do get withdrawal effects if you take them for a long period of time and you stop taking them. You can have withdrawal effects, but they're not addictive like opiates are addictive. They're not addictive like benzodiazepines are addictive. They're going to cause some withdrawal effects, but if you taper, you should be okay. And they're effective. They're just as effective as tricyclics, probably more so. And they work probably in 60% of people. Maybe 70% sometimes. You still have 30%, 40% of people that don't respond to these drugs, the SSRI drugs. They don't work. And some people take them and they work, and then they stop working over a long period of time. They kind of poop out. They describe it as the poop out effect. And you may need to increase the dose, or you may need to add something else or change the class of drug to get over that poop out effect. They only work on serotonin. They do not touch norepinephrine. So the tricyclics work on both serotonin and norepinephrine. The SSRI drugs only serotonin. They include Prozac, fluoxetine, Zoloft, which is sertraline, and Lexapro, which is escitalopram. You have other drugs like Luvox, that's an SSRI drug. There's a whole bunch of different ones. Paxil. The benefits are they work. They're on par with tricyclics. They work about the same effects, but less side effects, right? So their efficacy is similar, but they're much safer. There's less side effects. You can't overdose on them. Like tricyclics, you can be in trouble if you overdosed on it. These drugs really get serotonin syndrome, which can be easily treated. There are no dietary restrictions like the MAO inhibitors, so you don't have to worry about tyramine interaction effects. They're just easier to take. They're just better to take. Less side effects, less problems with overdose. They do have some undesired side effects, so you can still get weight gain with them. The weight gain is not the same level of weight gain you would get with a tricyclic antidepressant. So tricyclics have a lot of weight gain. SSRIs have slower weight gain, but some people do get weight gain. Some people actually get weight loss. So it's different depending on the person. Some people will be weight neutral. I would say Paxil is a drug that leads to more weight gain than some of the other ones. Zoloft is kind of mixed. Some people actually lose weight on Zoloft. Some people gain weight. Prozac is kind of weight neutral for the most part. Lexapro, people can gain weight on a long period of time. But the thing with antidepressants are the people that gain weight on antidepressants, generally they're not bothered by it because they feel better about themselves and the world in general. And the weight gain is not something that severely bothers them, although some people are bothered by weight gain. I'm not saying that people aren't bothered by weight gain, but it's a trade-off. Some weight gain versus a much happier life. I think people would pick the much happier life, but everybody's different. Some people will rather be depressed and not functioning. They're worried about gaining weight. So that's a problem. So these drugs are pretty effective in 60 to 70% of the population. Now, the other side effects of these drugs, the SSRI drugs, is that besides weight gain, it can reduce sex drive, and it can reduce sex drive to basically zero. So some people that take antidepressants, they have no desire at all for sex. And that may be upsetting to their partners. To them, it's not upsetting at all. They have no desire. So that's a side effect that people get frustrated with. And they try to take them off the drug maybe on the weekend sometimes to try to bump up the libido, but it's a libido killer in a lot of instances. You may have changes in your sleep cycle. Some people sleep more with SSRI drugs. Some people have insomnia with SSRI drugs. And that sounds kind of funny because of the whole depression can cause the same symptoms. Yes, well, depression causes the symptoms, and so does the treatment. Treatment causes the same symptoms as the depression causes. So whether it's weight gain, and the weight gain situation is because people tend to crave sweets, starches, fatty foods when they're on these SSRI drugs, at least anecdotally. You can't really go by the actual studies being done because the studies only look at the effects of the SSRI drugs over maybe 6 to 12 weeks, which is 4 months. Anything more than 4 months, there's not really a lot of studies on. They're looking at, does the drug work in the short term? What effect does it have? What side effects does it have? But it's not saying like, okay, 6 months from now, this is what you're going to have. There's no studies on that. Obviously, they're not funded by the pharmaceutical companies because the pharmaceutical companies don't care. They only want to show that the drug works and it's safe. They don't care if you're on the drug for 2 years that you're going to gain weight. And gaining weight is not something that's going to stop the drug from going to market or even diminishing your sex drive. It's a side effect, but it's not going to stop the drug going to market. So these side effects noted in people are anecdotal, and they occur over a long period of time, more than usually 6 to 12 weeks. The sleep problems, the sex libido issues, the weight gain, those are very common side effects for the SSRI drugs. There are no arrhythmias, though, with SSRI drugs, so they're safer in that way than the tricyclics. And they're less sedating than the tricyclics as well, because they don't bind to histamine receptor sites. So the SSRI drugs came online in the 80s. And then in the 90s, you had a new class of drugs called the SNRI drugs, the serotonin norepinephrine reuptake inhibitor drugs. And this is composed of Cymbalta and Effexor primarily. these drugs increase both serotonin and norepinephrine, and they can be more stimulating than the SSRI drugs. So if you have an anxiety disorder, these drugs may be difficult to tolerate. These drugs, I would say, are better for just pure depression because they're a little more stimulating because they're hitting norepinephrine. And someone with depression and anxiety may feel more anxiety, especially at the beginning of taking the drug for several weeks. May cause panic attacks and other things until your body sort of regulates it, and then you'll feel better. But those first several weeks might be kind of difficult for people that are very prone to anxiety. Now, Cymbalta has been studied also for pain, just like the tricyclics has been studied for pain. And they've prescribed Cymbalta for chronic back pain, and it seems to work pretty effectively for an antidepressant to treat chronic back pain. So that's interesting. The other issue with these are they do have some gastrointestinal side effects. So nausea, vomiting can be significant at the beginning of trying these drugs. There's a mix between weight loss and weight gain. There are people that lose weight on Cymbalta and Effexor, and there are people that gain weight on Cymbalta and Effexor. So it depends, right? But this is if you try the SSRI drugs first, they don't work, and your anxiety level is manageable, then SNRI drug could be something to follow up on, and they're pretty safe drugs except for the possible short-term increase in anxiety. And of course, as I mentioned, there's antidepressant failure. Sometimes the antidepressant doesn't work. Even the most successful of antidepressants fails to help at least 35% of clients. So I said 65, 70%. That means 30, 35% people, it doesn't work. And there's an even smaller percentage of those clients where multiple antidepressants don't work. And that's where you get into the conversation about, doing the electroconvulsive therapy, ECT, or doing some other brain therapy, which I'm going to talk about shortly. If multiple courses of antidepressants, both SSRIs, tricyclics, SNRIs, if they all don't work, and you've tried many, it's been going on for years, and nothing is working for you, then ECT, possibility, or maybe some other newer brain stimulation techniques can work for the really persistent, hard to treat depressive episode. So in recent years, 3 additional biological approaches have been developed to treat depression. One is the vagus nerve stimulation. The second one is the transcranial magnetic stimulation. And the third one is deep brain stimulation. So vagus nerve stimulation is they implant an electrode, right? Electrode pulse generator under the skin in your chest. And they hook up the end of the electrode to your vagus nerve, which is the 10th cranial nerve, right? It runs from your brain, down your brainstem, all the way down to like the gut. So it's very much connected to the brain and the gut. There's been some evidence suggesting that vagus nerve stimulation increases parasympathetic nervous system activity, right? So the parasympathetic nervous system slows everything down, deals with the stress response and slows everything down. And there's some evidence that by stimulating the vagus nerve, you can reduce levels of depression. So do this little surgery, they put it under your skin by your chest, they hook it up to your vagus nerve, and it emits like pulses, electronic pulses, that's done over constantly throughout the day and throughout the night. So you keep stimulating that vagus nerve, and they said that it brings relief to about 40% of people with treatment-resistant depression, which is really high. It's a very positive treatment. And like ECT, they don't know exactly why it works. I mean, it stimulates the vagus nerve, and is the vagus nerve playing a role in dealing with stress, maybe? Possibly. But by stimulating the vagus nerve, you're reducing depression. Side effects are minor. They mostly involve a sore throat or hoarse throat because of the stimulation that occurs right at the base of the neck there. And so you may have some, vocal discomfort temporarily. But other than that, there's no tremendous dangers associated or side effects associated with vagus nerve stimulation. The other issue would be that this was originally developed to treat seizures. So it's been done on people with seizures for over 45 years. So the safety profile is pretty high. So they've done this for a while now. They know that it's pretty safe, and that surprisingly it does work with some people for depression. So if you've tried all the different drugs and they don't work, and maybe you're not willing to go to ECT because you're afraid of the memory issue, there's no memory issue with vagus nerve stimulation. It's a relatively quick outpatient surgery, and the side effects are minimal. And it's something that may be worth trying for people with treatment-resistant depression. Here's a diagram of the pulse generator implanted right by the chest there, underneath the skin there. So it's a very minor surgical procedure. And they just basically rope up the electrode to tie in to stimulate the vagus nerve. And you're not going to feel it. It's underneath your skin. You're not going to feel it. It's not going to bother you. The only thing it may do is irritate your throat. You may sound, because the electrical impulses may interfere with a little bit of your ability to talk temporarily. Other stimulation techniques include transcranial magnetic stimulation, where you stimulate the brain without the bad side effects of ECT. And transcranial magnetic stimulation is basically a magnet. It applies it's almost like an MRI. So they pulse this electromagnetic pulse is repeated constantly while you're in the machine. And they've shown that if you do this on a regular basis over a period of weeks, it reduces depression. So it's a low-level electromagnetic pulse, similar to an MRI, in strength of an MRI, taking pictures, right? It's a magnet. And it doesn't have any known long-term side effects. And they think it interferes somehow in the electrical activity of the brain, and that leads to a reduction of depression. So the idea here is that it's benign, it's safe. They've done some research on it. They've actually used it to disrupt the activity in the occipital lobe. So if you take the transcranial magnetic stimulation machine and you focus it on the back of the skull, where the occipital lobe is, the primary visual cortex, and you pulse it, you let it emit electromagnetic pulses, what happens is it temporarily can blind you for a fraction of a second. That pulse applied to the back of your skull can lead to temporary visual blindness. It's really interesting. So it's disrupting the activity of that primary visual cortex, back of your skull. And so when applied to the full brain, it's disrupting the activity on some level that entails depression. And it's being studied. We don't know exactly how it works, but we know that people that have gone through trials of it, there's been minimal, if no, side effects. Another technique is deep brain stimulation. Here's a little more invasive one because this is actual brain surgery. They basically go down into your brain and they find an area of the brain called Brodmann's area 25. And it's part of the cingulate, which is an area of the brain that's involved in attention and focusing on different things in your environment. And they've identified this area of the brain as kind of like a switch that can turn depression on and off. And if you implant an electrode in the brain, so it's brain surgery. It's not like the vagus stimulation, which is a minor surgical procedure, and transcranial magnetic stimulation is just a magnetic pulse. This is actually brain surgery, so obviously there's more risk involved. They have to actually go into your brain and install an electrode that then stimulates this Brodmann's area 25. And by stimulating Brodmann's area 25, they've shown a great relief of people with treatment-resistant depression. So this is a new technique that's being studied now and is being offered, but it's not like a prominently offered therapy. The most prominently offered therapy outside of drugs is probably ECT, but now you have vagus nerve stimulation that they're doing research on. You have transcranial magnetic stimulation. You have deep brain stimulation. So these are alternatives. And ECT has a lot of bad side effects. So will these techniques eventually take over the role that ECT, electroconvulsive therapy, is playing? And the answer is probably. We just have to identify which one's the most effective and has least side effects. And you still need data collection on that. Treatment of bipolar disorder is a little bit more complicated. It's not ideal. It entails the use of lithium, which is a metallic salt, and other mood stabilizers. So lithium is the primary treatment, has always been the primary treatment for bipolar disorder. The problem with lithium is it's a dangerous drug, right? It's a toxic mineral that if you take in too high of a dosage, you could actually die from it. Now, you're not going to die from it because it's regulated very carefully, and the dosage is regulated. You just can't take more than you need to take because it's toxic. It is effective. It does stop manic episodes. It does have a ton of side effects. Extensive weight gain, extreme lethargy. Just, people feel miserable on it. They don't want to take it. The weight gain is ridiculous on lithium. They just feel sluggish. Their thoughts are slowed. Their actions are slowed. So for many people that want to slow down or stop the mania, it's doing too much. It's not only stopping the mania, but it's making the person feel extremely sluggish, extremely, gaining weight at extreme rates, and people hate it. And as a result, they stop taking their medication, and then they go back into the manic episode. And that's the problem with lithium. It's a terrible drug, and people hate taking it, and they stop taking it whenever they can. There's a lot of non-compliance with lithium. And you have to find the correct dosage, and like I said before, it can be toxic. So if you give too much, you're basically poisoning someone. So to me, it's a difficult drug to take, even though it is effective. You also have now Depakote, which is used as a mood stabilizer to stop mania. And Depakote is a drug that also has a lot of side effects. Weight gain is a prominent side effect. I think it's safer than lithium. I think Depakote is a much safer drug than lithium, but it has a lot of side effects. Besides weight gain, hair loss, things like that. People just are not thrilled with this stuff, right? People don't want to gain a lot of weight. They don't want to lose their hair. They don't want to feel like sluggish. So these drugs are difficult. They're very powerful drugs, but they do effectively stop the manic episode. And they make the major depression easier to treat with other antidepressants. So they are effective, but they have too many. The side effect profile is kind of difficult for many people to accept. You also have Abilify, which is a mood stabilizer, can be used instead of Depakote and lithium. Abilify is a newer drug that's shown some promise in treating bipolar. And they will also give Seroquel, which is an atypical antipsychotic. So it's a second-generation drug used to treat schizophrenia. The thing with Seroquel is it's very effective at stopping a manic phase, especially when people can't sleep. So if you're in a manic phase, you have no need for sleep at all. And Seroquel will basically calm you down to the point where it will heavily sedate you in a lot of cases and allow you to sleep. And it's used off-label as a sleeping pill for people with severe sleep disorders. It basically gets someone to sleep. If someone's severe insomniac and they haven't had success with Ambien or Lunesta or Rosarum or some of these other sleeping aids, Seroquel is something that will work tremendously. It's it's taking an antipsychotic. So once again, heavily sedating, weight gain, sluggishness, the next day sluggishness. But it's very commonly given to people that are psychotic, and it's used for manic phase of bipolar as well. The efficacy of bipolar meds, they work. More than 60% of people with mania improve on these meds. However, they're difficult to put up with the side effects. So they're effective for a lot of people, and they can even prevent symptoms of mania from developing. So they can be used prophylactically. Now, you don't want to really use these drugs prophylactically because these are powerful drugs. Lithium is a toxic drug. Depakote and Abilify are very powerful drugs. They're also, strangely enough, Depakote is used also for migraines, and it's very effective for preventing migraines, prophylactically preventing them. But with the problematic side effects, especially the weight gain and the hair loss, people generally don't want to stay on them. Once they find out about these drugs and they notice, they're in the shower and their hair's falling out, they're in mass panic mode, and that's it. There's no going back to these drugs after that. So they're effective for bipolar, they're effective for migraine, severe migraine, but they're actually the Depakote's for migraine. Lithium is not good for migraine. Lithium is a terrible drug. Depakote's a little bit better, and Abilify is a little bit better, but there are heavy side effects with those drugs. And these mood stabilizers, not only do they stop the manic episode, but they decrease the severity of the depression. So the person may need less of the antidepressant because the depression is not as severe as it used to be. So they're effective drugs, but if no one wants to take them because of the side effect profile, they're not effective. You can force someone to take it in the hospital because they have no choice. But once they're discharged, they don't want to take the drugs. Just like the antipsychotics, the patients don't want to take the drugs because the side effect profiles are too extreme. And they may feel better, and they may feel more even in terms of their mood. They may feel less depressed, and they don't have the mania to deal with. But is it worth the horrible side effects? And everybody has to make the decision, and most people say no. They want a drug that fixes their problems and has minimal side effects. And unfortunately, in the case of bipolar, that doesn't exist. There's no drug that's going to fix their problems and have basically no side effects. And there's a trade-off, and a lot of people aren't willing to accept that trade-off, and that leads to being admitted to the hospital, being discharged, given drugs to take as an outpatient. People are non-compliant with the drugs, then they get relapsed, and they're back in the hospital again. It becomes a vicious cycle that you see all the time, relapsing, discharge, relapsing, discharge, because people don't take their meds. And it's hard to blame them because the meds are difficult. You have to be willing to deal with these side effects in order to treat your problem. Psychotherapy for bipolar, as I said before, if someone's in a manic phase, having psychotherapy with them is going to be very interesting. Not very productive, but very interesting. They're going to talk really rapidly, and there's nothing you can say or do. They're going to be switching. They're going to be engaging in what's called loose associations, which is another symptom of psychosis. They're going to switch from topic to topic to topic, and it's going to be a very ineffective yet very interesting therapeutic session. The goal here is basically get them on the drugs, crush the manic phase, right? Get rid of the mania, make the depression a little bit more manageable. And once that happens, and they're on the medications, now you're able to really treat the depression through psychotherapy. It's tough with mood stabilizing drugs. Like I said, the side effects are bad, but they work. And to just treat someone with therapy and no drugs and treat someone with bipolar, full-blown manic episode with this is virtually impossible. So the therapy is used as an adjunctive to the medication, and it works in that role. It's not used in absence of the medication. Patients must take their medication, and then if they do therapy, it's going to help them more. You can't just get through talk to someone in a manic phase and do a therapy session with them. It's not going to work. So basically, that's it for this long chapter. Sorry for the very long video, but there's a lot to talk about here. So I hope you enjoy it. You can break it up into little pieces and rewatch it. And hope it's helpful. And I'll see you next week. Start working on the exam 2 review sheet for the exam that's going to be happening in another week or two. Okay? Bye for now. If you have questions, please send me an email or stop by the office hours.